All right, get ready because we're diving deep today
Mm-hmm.
into the world of hormones, specifically the link between hypertension and hypokalemia.
Oh, a fascinating connection.
It is. And you know what? You sent us some info on this.
Right.
And it turns out there's a surprising connection to primary aldosteronism.
Yeah, what's really interesting is
What's interesting?
that primary aldosteronism is often an overlooked cause of hypertension. You'd think low potassium would be a clear sign, right?
Right.
But get this, a study across 5 international centers found that
Okay.
less than 50% of diagnosed cases actually presented with hypokalemia.
Wow. Less than half.
Yeah,
That's way less common than I would have thought.
it is surprising.
So this primary aldosteronism, it's more than just a blood pressure issue.
Yeah, it's linked to an increased risk of some serious cardiovascular problems,
Oh, like what?
like stroke
Oh, wow.
and heart attacks,
Okay. That definitely makes this deep dive important.
for sure.
So let's start with the basics. What exactly is primary aldosteronism and how does it usually show up?
Think of it as your adrenal glands going a little overboard
Okay.
with aldosterone production.
Mm.
This hormone's job is to keep your salt and potassium levels balanced.
Right.
But too much aldosterone
Mm.
leads to holding on to sodium and getting rid of potassium,
Uh-huh.
which can cause high blood pressure and low potassium.
So it throws the whole balance out of whack.
Precisely.
Okay.
The classic presentation, sometimes called the tricky triad, is hypertension, unexplained hypokalemia, and metabolic alkalosis.
Mm.
But as we've seen, that classic picture isn't always so clear-cut.
That makes sense considering that less than half of those diagnosed even have low potassium.
All right.
So if we can't rely on the classic triad, what should we be looking out for?
Well, there are some red flags.
Okay.
The Endocrine Society guidelines recommend screening for primary aldosteronism in certain groups
Uh-huh.
where the prevalence is higher.
Okay.
This includes folks with resistant hypertension.
Those who have incidentally discovered adrenal masses,
Mm.
and those with a family history of early onset hypertension or stroke.
So early detection is key, especially for folks with those risk factors.
Absolutely.
But there are other conditions that can mimic primary aldosteronism, right?
Yes, there are.
How do you tell them apart?
That's a great question.
Yeah.
There are definitely some mimickers and masqueraders, so to speak.
Okay.
Things like renovascular disease,
Uh-huh.
Cushing syndrome,
Okay.
and believe it or not, even too much licorice can cause similar symptoms.
Licorice?
Yeah,
Really?
Uh-huh.
I had no idea.
it sounds strange.
It does.
But licorice contains a compound that can act like a mineralocorticoid, mimicking the effects of aldosterone.
Hmm.
But to really differentiate these conditions,
Yeah.
we need to take a closer look at the renin-angiotensin-aldosterone system.
Okay, let's unpack that a bit.
Sure.
You mentioned the plasma aldosterone to renin ratio,
Yeah.
or PAC-PRA earlier.
What role does that play in diagnosis?
The PAX-PRA ratio is incredibly helpful.
How so?
Well, it tells us if the amount of aldosterone being produced is appropriate for the level of renin activity. Renin is an enzyme
Okay.
that kicks off a chain reaction that ultimately leads to aldosterone production.
So high aldosterone and low renin.
Yeah.
That's
Yeah.
a red flag.
You got it.
Got it.
A high PAC-PRA ratio is a strong indicator of primary aldosteronism.
Okay.
But, and this is important,
Okay.
the exact cutoff values can vary between labs, and certain medications can impact the results, so we have to take those into account.
Ah, the joys of medical detective work.
Right.
So if the PAX-PRA ratio is high, is that enough to confirm a diagnosis?
Not quite.
What else do you need?
We need confirmatory tests to be absolutely sure.
Like what?
One common method is the saline infusion test,
Okay.
where we literally infuse saline solution and see how your body responds.
Okay.
In primary aldosteronism, aldosterone levels stay high, despite the salt load.
That's pretty clever.
It is a useful test.
But what if those initial tests suggest something other than primary aldosteronism, even though the symptoms seem similar?
That's where things get really interesting.
Ooh, I like interesting.
We have to consider the possibility of non-aldosterone mineralocorticoid excess.
Okay, break that down for me.
Basically, this means there's something else acting like aldosterone in your body,
Okay.
causing those same effects on salt and potassium.
Intriguing.
Is it?
Besides our licorice-loving friend,
Right.
what else could cause this mineralocorticoid imposter syndrome?
There are a few culprits.
Like what?
For instance, some types of congenital adrenal hyperplasia, where certain hormones are overproduced,
Okay.
or the aptly named apparent mineralocorticoid excess syndrome, a rare genetic condition.
Wow.
Even severe cases of Cushing's syndrome can lead to cortisol behaving like a mineralocorticoid.
So many layers to this hormonal puzzle.
There
But
are.
let's say we've confirmed a diagnosis of primary aldosteronism.
Okay. What happens next?
Well,
Is the treatment the same for everyone?
not at all.
Really?
Treatment depends on the root cause.
Okay.
That's why it's crucial to figure out
Yeah.
whether we're dealing with an aldosterone-producing adenoma, which is a benign tumor on the adrenal gland,
Right.
or bilateral hyperplasia,
Okay.
where both adrenal glands are overproducing aldosterone.
So we need to figure out which adrenal gland, or both,
Yes,
are causing the trouble.
exactly.
How do we do that?
Traditionally, we've used adrenal CT scans to classify the subtype. They help visualize the adrenal glands and potentially spot a tumor.
So a clear adenoma on the scan means surgery.
Right.
And if both glands look suspicious,
Yeah.
it's medication time.
Sounds straightforward.
Yeah.
But there's a catch.
Oh, what's the catch?
CT scans, while helpful, aren't foolproof. They can miss small adenomas.
Oh, no.
And sometimes even mistake a non-functioning adrenal nodule for an aldosterone-producing one. So how do we make sure we're making the right treatment decisions?
This is where a test called adrenal vein sampling, or AGS, comes in.
Okay.
It's considered the gold standard
Okay.
for accurately distinguishing between unilateral and bilateral causes.
Okay, so AVS is like the ultimate tiebreaker.
You could say that.
But how does it actually work?
It involves threading a catheter through a vein in the groin all the way up to the adrenal veins
Wow.
to directly sample the blood coming from each gland.
That sounds pretty high-tech.
It is a specialized procedure.
Is it worth the effort?
Absolutely.
Really?
Studies have shown that relying on CT scans alone
Yeah.
can lead to a significant number of patients receiving inappropriate treatment.
Wow.
This means people might miss out on potentially curative surgery for an adenoma or end up on medication when surgery would be the better option.
Wow, that's a pretty compelling argument for AVS.
I think so.
So once we know the subtype, treatment can be tailored accordingly. But are there any other factors we need to consider in managing primary aldosteronism?
One more piece of the puzzle we need to mention is genetic testing.
Oh, okay.
There are rare forms of familial hyperaldosteronism, which, as the name suggests, are inherited.
Interesting.
Identifying these can be important for both you and your family members.
That's fascinating.
It is.
So even within this seemingly specific condition,
Right.
there's a whole world of complexity.
Absolutely.
It's amazing how much we've learned about primary aldosteronism.
Yeah.
And it sounds like there's still more to discover.
There's always more to learn.
This is really interesting stuff.
It is a fascinating area of medicine.
It really is amazing how much depth there is to what might seem like a straightforward medical condition.
It's like peeling back the layers of an onion.
Speaking of layers, let's talk more about adrenal vein sampling.
Sure.
Sounds pretty specialized.
It is, and for good reason.
Okay.
AVS requires a skilled interventional radiologist who's experienced in navigating the delicate anatomy of the adrenal veins.
So, not something you'd order on a whim.
Definitely not.
Can you walk us through what actually happens during the procedure?
Of course.
Okay.
The patient lies on their back,
Okay.
and the radiologist uses imaging guidance, usually X-ray, to insert a catheter into a vein, typically in the groin.
Okay.
The catheter is then carefully threaded up towards the adrenal glands.
I imagine it's like threading a needle through a maze.
A very delicate maze. That's a good way to put it.
And then...
Once the catheters are in place, blood samples are taken from both adrenal veins
Okay.
and the inferior vena cava, the large vein that carries blood back to the heart.
Right.
This allows for comparison of aldosterone levels from each adrenal gland
Okay.
to determine if one is producing significantly more aldosterone than the other.
That makes sense.
Yeah.
You mentioned that cosyntropin, a synthetic form of ACTH, is often used during AVS.
Right.
Why is that?
Cosyntropin acts like a booster shot for aldosterone production. By administering it before taking the blood samples, we can amplify the difference in aldosterone levels between the two adrenal glands,
Okay.
making it even easier to spot a problematic adenoma.
Ah, so it's like turning up the volume on the signal.
Exactly.
So by using this booster shot,
Yeah.
we're ensuring we get the most accurate picture possible.
Precisely.
But how do we know the catheters are even in the right spot?
That's a good question.
And what do the results tell us?
To confirm we've successfully placed the catheters,
Yeah.
Cortisol levels are measured in the blood samples.
Okay.
Since cortisol is also produced by the adrenal glands,
Right.
a significant jump in cortisol levels when we hit the adrenal vein tells us we're in the right place.
Oh, so it's like a built-in confirmation system.
Exactly.
Very cool. So we've got our samples
Yes.
and confirmed our placement.
Right.
How are these results interpreted?
Well,
Is there a magic number that screams adenoma?
it's not quite a magic number,
Okay.
but there are cutoff values that guide our interpretation.
Hmm.
We calculate what's called a cortisol-corrected aldosterone ratio,
Okay.
which takes into account the potential dilution effect of other veins feeding into the adrenal vein.
So we're adjusting for any background noise in the samples to get a clearer picture.
Exactly.
So this gives us a clearer picture of
Yeah.
what each adrenal gland is truly producing.
Exactly.
Okay.
Generally, a ratio greater than 4:1 between the two adrenal glands strongly suggests a unilateral adenoma.
So the higher the ratio,
Yes,
the more likely it is that one gland is the problem.
that's correct.
What about ratios below that threshold? Does that automatically mean bilateral hyperplasia?
Not necessarily.
Okay.
There's a bit of a gray zone.
Okay.
Ratios between 3:1 and 4:1 can be trickier to interpret.
I see.
It might indicate bilateral hyperplasia,
Uh-huh.
but it could also point to a small adenoma that's not producing quite as much excess aldosterone.
So some cases might require a bit more investigation,
Right.
perhaps additional imaging,
Yeah,
or even a repeat AVS down the line.
exactly.
We have to consider the whole clinical picture,
Yes.
not just a single number.
That's right.
The patient's age, severity of symptoms, and other medical conditions all factor into the decision-making.
You do?
It's like putting together a complex puzzle using all the pieces of information at our disposal.
That's a good analogy.
Let's talk more about the genetic factors you mentioned earlier.
Sure.
What are the different types of familial hyperaldosteronism, and how do they differ from the more common sporadic forms?
There are three main types: familial hyperaldosteronism type I,
Okay.
type 2,
Uh-huh.
and type 3.
Okay.
Type I,
Yeah.
also known as glucocorticoid remediable aldosteronism, or GRA,
Okay.
is unique because the overproduction of aldosterone is driven by ACTH, the same hormone that regulates cortisol production.
So in GRA, it's like the aldosterone production is being controlled by the cortisol system.
You got it.
Interesting.
And because of this unique connection,
Yeah.
GRA can actually be managed effectively with glucocorticoids like dexamethasone.
Fascinating. So treatment involves suppressing ACTH production,
Right.
which in turn lowers aldosterone.
That's right.
What about the other types?
Type 2 familial hyperaldosteronism is a bit more mysterious.
Oh, how so?
We haven't definitively identified the genetic cause, and it can present as either an adenoma or bilateral hyperplasia.
So there's more variability in presentation,
There is.
but it's still treatable depending on the specific subtype.
Correct.
What about type 3?
Type 3 is incredibly rare
Okay.
and is caused by a specific mutation in a gene involved in potassium channels within the adrenal gland. This mutation leads to excessive aldosterone production and often results in severe, difficult-to-control hypertension.
That sounds challenging to manage.
It can be.
So when should genetic testing be considered in patients with primary aldosteronism?
There are a few key things that should raise a red flag.
Okay, like what?
Patients diagnosed at a young age, especially under 20,
Okay.
those with a strong family history of primary aldosteronism, or those with particularly severe or resistant hypertension,
Okay.
should all be evaluated for potential familial forms.
That makes sense.
Yeah.
Early identification is important not just for the patient, but for their family as well.
Absolutely.
If you have a family history of hypertension, this is definitely something to keep in mind.
For sure.
Now let's shift gears for a moment
Okay.
and talk about the broader implications of primary aldosteronism.
Sure.
You mentioned earlier that it's linked to a higher risk of cardiovascular complications.
Right.
Could you elaborate on that?
Absolutely.
Okay.
It's not just about the high blood pressure itself. It's the way aldosterone directly affects the heart and blood vessels.
Okay.
High aldosterone can lead to inflammation, fibrosis,
Okay.
and stiffening of the arteries,
Yeah.
which all increase the risk of heart attack, stroke,
Uh,
and heart failure.
so it's a double whammy.
It is.
High blood pressure and direct damage to the cardiovascular system.
Exactly.
That's why early diagnosis and proper management are so important.
Absolutely.
We're not just treating blood pressure numbers.
No.
We're aiming to prevent long-term damage.
Yes.
And improve overall cardiovascular health.
Precisely.
It really highlights the importance of looking beyond the surface.
It does.
And considering underlying hormonal imbalances.
Yes, very important.
So what happens if primary aldosteronism is left untreated?
Mm.
What are the long-term consequences?
Imagine this.
Okay.
A patient has persistently elevated blood pressure. Despite taking your medications as prescribed,
Okay.
their risk of developing a thickened heart muscle increases, putting a strain on the heart's ability to pump efficiently.
Oh.
Their arteries are becoming less flexible, making them more prone to plaque buildup and blockages. And their risk of experiencing a stroke, a potentially life-altering event, goes up.
That's a sobering thought.
It is.
It really underscores how important it is to take hypertension seriously
Yes.
and look deeper when those red flags appear.
Absolutely.
We can't just assume it's garden variety hypertension.
We can't.
We have to be vigilant,
We do.
especially in those high-risk groups.
Yeah.
And consider the possibility of primary aldosteronism.
Right.
Early intervention can make a real difference in preventing these long-term consequences.
It can.
It's like the saying goes, an ounce of prevention is worth a pound of cure.
Exactly.
But let's talk treatment options now.
Sure.
We know it depends on the underlying cause.
It does.
So let's break it down.
Okay.
What's the approach for an aldosterone-producing adenoma?
Surgery,
Okay.
specifically laparoscopic adrenalectomy, where the adenoma is removed through a minimally invasive procedure.
Okay.
This is often curative, which means blood pressure normalizes, and the risk of complications decreases significantly.
So a relatively straightforward solution for a complex problem.
In many cases, yes.
What about bilateral hyperplasia?
Right.
Surgery isn't an option in that case, right?
You're right.
Okay.
With both adrenal glands involved,
Uh-huh.
we can't simply remove them.
Okay.
Instead, we use medications that block the effects of aldosterone.
Okay.
These are called mineralocorticoid receptor antagonists, or MRAs.
Ah, like spironolactone,
Yeah,
which is also used to treat heart failure.
that's right.
So you're essentially preventing aldosterone from acting,
Yes,
even though it's still being overproduced.
correct.
These medications can effectively control blood pressure
Yes,
and normalize potassium levels in most patients with bilateral hyperplasia.
that's right.
That's great.
It is an effective treatment option.
Are there any drawbacks to using MRAs long-term?
There can be side effects,
Like what?
such as breast tenderness or enlargement in men, and menstrual irregularities in women.
Okay.
We also need to be mindful of potential interactions with other medications,
Right.
but overall, MRAs are generally well tolerated,
Okay.
and the benefits outweigh the risks for most patients.
That seems like a reasonable trade-off to prevent those long-term cardiovascular problems.
I agree.
You mentioned earlier that certain medications could affect the PASI-PRA ratio used for screening.
Yes.
Can you tell us more about that?
Of course.
Okay.
Some medications can either raise or lower components of the renin-angiotensin-aldosterone system, making the ratio less reliable.
Okay.
For example, spironolactone and eplerenin.
Yeah.
The MRAs we just discussed
Right.
can actually increase renin levels,
Okay.
potentially masking the suppressed renin that's typically seen in primary aldosteronism.
So if someone is already taking spironolactone,
Yes.
the ratio might not be accurate for screening.
Exactly.
Got it.
It's important to take medication history into account when interpreting the PASI-PRA ratio. And sometimes we might need to temporarily stop certain medications to get a clear picture.
That makes sense.
Yeah.
We wouldn't want to miss a potential diagnosis because of medication interference.
No, we wouldn't.
What about other antihypertensive medications?
Sure.
Do they impact the ratio as well?
Some can.
Okay.
For instance, beta blockers can lower renin levels, which could make the ratio appear falsely elevated.
Okay.
But here's the key.
Okay.
Even though beta blockers can affect the ratio, they don't usually cause aldosterone levels to be high enough to raise a red flag.
So a slightly elevated ratio while taking a beta blocker might not be concerning,
Right.
but a very high ratio is suspicious regardless of medication.
Exactly.
Okay.
It's all about context.
Right.
We consider the specific medications,
Uh-huh.
the degree of elevation in the ratio,
Yeah.
and the overall clinical picture.
So it's like solving a puzzle, piecing together all the clues
Right.
to get to the most likely diagnosis.
Exactly.
Speaking of puzzles, let's go back to those less common causes of hypertension and hypokalemia
Sure.
that can mimic primary aldosteronism.
Right.
We talked about Cushing's syndrome
Aye.
and licorice ingestion.
Yeah.
But what about renovascular disease? How does that fit into all of this?
Renovascular disease,
Yeah.
which is a narrowing of the arteries that supply blood to the kidneys, is a fascinating example of how the body's feedback mechanisms can backfire.
Interesting. How so?
When blood flow to the kidneys is reduced,
Okay.
it triggers the release of renin,
Right.
that enzyme that kicks off the cascade, leading to aldosterone production.
Right. Renin leads to angiotensin,
Yes.
which then stimulates aldosterone production.
Exactly.
So in renovascular disease, both renin and aldosterone are elevated?
Precisely.
Okay.
That's a key difference from primary aldosteronism, where renin is suppressed.
Got it.
So in renovascular disease, we see a high PAS-PRA ratio,
Yeah.
but it's because of the high renin,
Right.
not autonomous aldosterone production.
Ah, I see.
Yeah,
So the ratio alone can be misleading.
it can.
We need to look at the individual components,
We do.
both renin and aldosterone,
Yes,
to get the full picture.
that's right.
How do you differentiate between renovascular disease and primary aldosteronism then?
Imaging studies,
Yeah.
such as renal ultrasound or CT angiography, help visualize the artery supplying the kidneys
Okay.
and identify any narrowing or blockages.
So you're looking for a physical cause,
Right.
a plumbing problem.
Yeah, you could say that.
That explains the hormonal imbalance.
Exactly.
What about treatment?
Yeah.
Is it different from how you treat primary aldosteronism?
Treatment for renovascular disease focuses on addressing the underlying blockage.
Okay.
This might involve angioplasty,
Uh-huh.
which uses a balloon to open up the narrowed artery,
Okay.
or stenting,
Yeah.
where a small mesh tube is inserted to keep the artery open.
Okay.
Sometimes medications to control blood pressure and prevent blood clots are also needed.
So a different approach, but with the same goal.
Right.
Control blood pressure
Yes,
and reduce the risk of those long-term complications.
exactly.
What if you've ruled out primary aldosteronism, renovascular disease,
Yeah.
and all the usual suspects,
Right.
but you're still puzzled?
Hmm.
Are there any other rare conditions to keep in mind?
There are a few more obscure possibilities.
Like what?
For example, Little syndrome
Okay.
is a rare genetic disorder that mimics the effects of aldosterone, even though aldosterone levels are actually normal.
Ah, so another mineralocorticoid imposter.
Exactly.
What causes Little syndrome?
It's caused by a mutation in a gene that regulates sodium channels in the kidneys. This leads to excessive reabsorption of sodium, which drives up blood pressure
Okay.
and causes potassium loss,
Right.
just like we see with high aldosterone.
Interesting. So even though aldosterone isn't the culprit,
Right.
there's still a sodium and potassium imbalance.
Exactly.
How do you diagnose this genetic condition?
Genetic testing can confirm the diagnosis.
Okay.
And thankfully, Little's syndrome responds well to specific medications
Yeah.
that block those overactive sodium channels.
It's amazing how understanding the underlying mechanisms can lead to targeted treatment.
It really is.
Before we wrap up,
Sure.
I'd like to circle back to something you mentioned earlier,
Okay.
that the prevalence of primary aldosteronism is higher than we once thought.
It is.
Why is this condition being diagnosed more frequently now?
It's a combination of factors.
Like what?
Increased awareness among healthcare providers is a big one.
Okay.
We're getting better at recognizing the subtle signs
Uh-huh.
and ordering the appropriate tests.
Makes sense.
Also, the availability of more sensitive and accurate diagnostic tools like the PAS-PRA ratio has made a big difference.
So we're getting better at finding those needles in the haystack.
That's a good way to put it.
But what does this mean for the future of hypertension management? With primary aldosteronism potentially affecting more people than we realized, should everyone be screened?
That's a great question, and it's still being debated.
Okay.
Routine screening of all patients with hypertension would undoubtedly lead to more diagnoses, but it would also be costly and might not be practical or necessary for everyone.
It's a classic balancing act.
Yes.
Weighing the benefits against the potential downsides.
Exactly.
What factors should clinicians consider when deciding whether to screen for primary aldosteronism?
It's important to think about the individual's risk factors.
Okay.
Do they have resistant hypertension, hypokalemia,
Yeah.
or a family history of early onset hypertension or stroke?
Right.
Are they young and otherwise healthy, which makes a curable cause like an adenoma more likely?
Okay.
These factors can help guide our decisions and ensure we're focusing on those who are most likely to benefit from screening.
So it's about personalizing the screening strategy based on each person's circumstances.
Okay.
But beyond the individual patient,
Yes.
what are the larger implications of this evolving understanding of primary aldosteronism?
This knowledge has the potential to change how we manage hypertension.
How so?
It's prompting a shift from solely focusing on lowering blood pressure numbers to identifying and treating the underlying cause whenever possible.
It's a move toward precision medicine.
It is.
Getting to the root of the problem rather than just masking the symptoms.
Exactly.
And as our understanding of primary aldosteronism continues to grow, we'll be better equipped to diagnose and treat it effectively,
Absolutely.
ultimately leading to better outcomes for patients.
That's the goal.
It really is a paradigm shift, moving away from that one-size-fits-all approach to hypertension.
It is, definitely.
But
Sure.
let's zoom out even further.
Okay.
We've been so focused on primary aldosteronism,
Right.
but this is just one piece of a much larger puzzle, right?
Absolutely.
Like what?
The endocrine system, it's a complex network of glands and hormones that regulate a vast array of bodily functions.
Right.
And when one part of the system is thrown off, it can create a domino effect throughout the body.
It's like a carefully choreographed dance,
Yeah.
with each hormone playing a specific part to keep everything in sync.
Right.
But when the rhythm is off, things can get pretty chaotic.
Yeah, it's a great analogy.
So primary aldosteronism is a perfect example
It is.
of how a seemingly isolated hormonal imbalance can have wide-ranging consequences.
Absolutely.
It affects not only blood pressure, but also cardiovascular health,
Right.
electrolyte balance, and even quality of life.
It can, yeah.
So what's the key takeaway for our listeners today? What should they be thinking about as they manage their own health?
I think the most important thing is to be proactive.
Okay.
Understand your risk factors for endocrine disorders. Pay attention to even subtle changes in your body, and don't hesitate to ask your healthcare provider questions.
It's all about being your own health advocate. Don't be afraid to push for answers and seek out specialists if needed.
I agree.
Early detection and proper management can make all the difference when it comes to preventing those long-term complications
It can.
and living a healthier, more fulfilling life.
Absolutely.
Well said. That's a perfect note to end on.
I think so, too.
Thank you so much for joining us on this deep dive into the world of hypertension, hypokalemia, and the often hidden culprit, primary aldosteronism.
It was my pleasure. Thanks for having me.
We'll be back soon with another deep dive into a brand new topic.
Looking forward to it.
Until then, stay curious, stay informed, and stay well.